green yet. Okay, we're live now. Okay. Right, let's start, and welcome to everybody online to the Siemens Healthcare Diagnostics Keynote webinar for the BioConference Live 2014. We're going to be talking about companion diagnostics and changing the face of healthcare. My name is Andrew Beard, and I'm the Senior Director of the Siemens Clinical Lab, Marketing and Companion Diagnostics, and I'm going to be the host and the facilitator of the webinar today. Next. We seem to be having some technical issues here, just pulling up the second slide. There we are, the second slide. Okay. Right. Okay, we're now back in business. I'm going to be giving a brief introduction to everybody online, the audience online, to companion diagnostics. This will be followed up by two presentations by our experts here. Dr. Patrick Joseph, who's our Medical Director of the Siemens Clinical Lab and a practicing physician. He's really going to be talking about companion diagnostics for making it personal for patients. That'll be followed by a presentation by Dr. Richard Frank, who's the Chief Medical Officer for Clinical Strategy and Policy for Siemens Healthcare. And he's going to be talking about a bit more of the reality of the world into which companion diagnostics are going to be born, talking about some of the trends in healthcare and the impact on companion diagnostics. At the end of this presentation, we'll be finishing with a Q&A and a panel discussion with our experts. If you wish to submit questions to our experts, on the left-hand side of your screen you should see a Q&A button. If you click that Q&A button, a text box should appear. You place your question in there, and that will appear on our computers here. And at the end of this presentation, we may have an opportunity to choose your questions for our experts to respond to. Okay, with that, I'd just like to move on to the first part of this presentation, which really what I'm going to be doing for the next 10 minutes or so to talk about an introduction to companion diagnostics. Companion diagnostics are more than just a hypothesis. It's actually a reality of today, but that's been very much reinforced by some primary research that we've been doing with our customer base, plus also a number of key opinion leaders around the world. We've identified 5 themes that are clearly going to shape the in vitro diagnostic industry and obviously the testing communities over the next few years. One of those pillars, if you like, or one of those 5 themes has been around precision medicine. And that's what we're really going to be talking about today, precision medicine. So let's start with some terminology, because it's often very confusing about what people mean. At least within industry, we talk about companion diagnostics, but typically when you're working with pharmaceutical partners, they also think in terms of precision medicine. At the end of the day, both more or less mean the same thing, but really they're both focused on the patient, really enabling personalized medicine for improved patient outcomes. And what that really means is that what you're trying to do is that you're applying tests to a population of possible candidates for a therapy, and obviously applying a biomarker to those, to testing those individuals, and that will result in selecting those a certain number of individuals who are most likely to respond to the therapy in question. One of the major drivers, if you like, of the companion diagnostics requirement is actually our expanding knowledge of disease, and it's increasing by the day, exponentially in many cases. Here's an example of how hematological malignancies were viewed over the last 100 years, starting off with a consideration of diseases of the blood, where the 5-year survival rate was more or less 0, to what we have today, where in this particular category of diseases, there may be up to 80 types of a combination of leukemias and lymphomas that you'd want to be able to identify. And it's often true to say that the therapies may well be targeted to either individual classes of the disease or in fact groups of the disease. And as you can see, as from this particular slide, over time as the therapies have improved and as they're going to improve in the future, the 5-year survival rates have improved dramatically. Well, for companion diagnostics to become a real reality, it's taken the pharmaceutical industry some time to recognize the value of testing alongside their therapies. And now it's actually a recognized model within the pharmaceutical development process. I think the most tangible evidence of how it's been embraced within industry is the fact that now the vast majority of pharmaceutical companies now have dedicated organizations and resources looking for the potential of tests to be used alongside their therapies, either in early stage development or indeed beyond in later stage development. In some cases, and you can see a quote at the bottom of this slide, where in this particular case the pharmaceutical company acknowledges that the vast majority of their therapies in development are indeed utilizing some kind of biomarker. If you look at specific disease states such as oncology, the adoption of biomarkers or adoption of companion diagnostics can cover more or less all the tests, all the therapies that are in development today, which is fairly impressive considering where it's come from if you go back 20 years ago. So where are we today? And I think if you go to the FDA website, you can review the number of companion diagnostic tests that have been approved. At this moment in time, there are 19 companion diagnostic tests and therapy combinations that are FDA approved. Now, this slide doesn't refer to all of them. It's just the most recent approvals that have taken place. But the take-home here is that this is effectively the tip of an iceberg. We think over the next few years, this is going to rapidly, the approvals of a combination of companion diagnostics and the therapies is only going to increase over time, and hence our conclusion that it's going to have a major impact on the diagnostic and the testing communities in the near future. So, in the development of these companion diagnostic tests, there are opportunities and challenges for a combination of ourselves as a diagnostics company, but also for our partners, especially the pharmaceutical partners, and of course the lab testing community, who are going to be clearly the vehicle for helping realize the potential of companion diagnostics in the future. I won't go through all the individual questions that are typically asked by each of the, shall we say, the stakeholders in the development of these companion diagnostic tests, but they kind of more or less condense into a few fundamental questions, some of which I think are going to be addressed by Dr. Franks later in his presentation on the healthcare environment. So the typical questions that are asked across the partnerships: what tests are used, how do they get used, who's going to be asking for those tests, and who's going to be asking for the tests, when will they be available, and fundamentally, who's going to be paying for those tests at the end of the day. So our approach, the Siemens healthcare diagnostics approach to companion diagnostics, is graphically represented in this next slide. And this is where we leverage our clear laboratory operations based in Berkeley, California. We develop essentially what we call lab-developed tests that are analytically validated, that are then utilized in clinical trials, and we undertake the clinical trials testing utilizing our clear lab operations. As the tests are developed, it obviously helps with the clinical validation through the access to the clinical trials, and ideally we end up in parallel developing diagnostic test kits that may well end up on our routine platforms of the future. These diagnostic test kits have access to the clinical samples from the clinical trials, and hence they become the candidates for the regulatory submissions and the approvals, which ultimately make the test available around the world in conjunction with the therapy, so that you have optimum patient access. So, my brief summary of companion diagnostics is represented in this next slide. It's all around clinical excellence, and should we term it on this occasion precision medicine. But it's really about the patient, where we're leveraging the best information, the best science in specific disease states. There's the choice of technology, and platform is obviously very important for the final deployment of those tests for patient access. And obviously we combine all these together to really help realize the full potential of companion diagnostics. So that's the end of my introduction to companion diagnostics. I'll now hand over to Dr. Patrick Joseph, our medical director of the Siemens Clinical Lab, who's going to talk to making companion diagnostics personal for patients. So Dr. Joseph.
Well, thank you, Andrew, and thank you for the nice introduction. Yeah, I have a very pleasant opportunity today, and that is to discuss the emotions of physicians and patients. So my talk, or at least the next few minutes, will be about the physician-patient interaction and my impression of how physicians and patients think. So as we enter this era of companion diagnostics and personalized medicine, I'm often asked, are physicians receptive to this, or will physicians be a bit of an obstacle to the progression? And I think I can answer that question today. So let's start with the definitions. Now, the first definition on the slide in front of you, where it says generic, is pretty much my verbiage, and that is it's a bioanalytical test, or any test that we might do in the laboratory, that's designed to assess whether or not a patient will respond to a drug. That is not the good definition, or at least the 21st century definition of a companion diagnostic. And I think that's better expressed by the FDA. And let me emphasize that. It is a bioanalytical test, or a diagnostic assay, that is essential for the safe and effective use of a drug. And not only that, it is often co-marketed with the drug, so that the package insert for the drug and the package insert for the test support each other, meaning that the package insert of the drug says that the companion diagnostic must show that this drug is likely to be effective. So let me go through some examples and try to show where I think we are today. This is the results of an antibiotic susceptibility test, and many times when I talk to some of my physician colleagues, they think that of this as a companion diagnostic. And in a way it is, but it's not what we're talking about today and not where we're moving to in the future. There's no question that this shows that for a given patient who may have a E. coli urinary tract infection, based on this simple table, that ciprofloxacin would be the best. But clearly ciprofloxacin is not have a listing in its package insert that this is essential for the patient to treat an E. coli urinary tract infection. This just tells us in an old way that this was a test that was designed to help treat a specific patient or many patients. So what I want to talk to you about is what physicians are faced with when they see a patient in the exam room. And I'm going to go through a couple of examples to emphasize this point. Now, what's on this slide are 7 different drugs. They're all of the same chemical class. They're all used to lower the LDL cholesterol, or the bad cholesterol. And you can see the percentage likelihood that each one of them may work. And many of them probably have an average of about 30% or 40%. But it's not the same 40%. So another way of saying that is one drug might work for one patient, and a different drug might work for another patient. But you don't know going into that. And this is a problem both for physicians and patients. And now it's also a problem for healthcare providers or payers. So many times what payers will say, and probably appropriately so, let's start off with the one that is most economical with the fewest side effects. And if that doesn't work, we'll stop that Then we'll go to a next drug, and if that doesn't work, we'll stop it and we'll try another drug. And this is the practice of medicine every day in a physician's office. So you can imagine what we're doing. Many times we're giving patients a drug that doesn't work, and they may be subject only to side effects, but we just don't know that. So this is a problem, and then there's the paperwork side of it that physicians often complain about, and I don't blame them. In order to give a drug that is not covered by a particular patient's insurance plan or coverage often requires additional paperwork, and although it's understandable, this is a problem that we have to deal with every day. Now the next slide is even more dramatic. Now, I know that many times when a speaker presents a slide like this, he or she will apologize for the complexity, and I'm not going to. This slide is one that I wanted to show because of its complexity. This is a flow chart for the management of Parkinsonism, or Parkinson's disease, as of 1 month ago. That is, as of April 2014. This is how a physician treats a patient with Parkinsonism. And if I were just to go down the flow chart on the left side, once a diagnosis of Parkinsonism is made, and bear with me for just a few moments, what you see in front of you is the first thing that a physician will pick is either an anticholinergic agent or a beta blocker, and then see how a patient does. And if they don't do well enough, then you can add or change to a dopamine agonist. And then further down, if that doesn't work, you can add levodopa or change that or stop the beta blocker. And if that doesn't work, often you add a drug called clozamine. And this is what one has to do today. Now, wouldn't it be wonderful if a patient was diagnosed with Parkinson's disease and there was a diagnostic test that could be done that would say, for that patient, this is the drug you want to use. And that's what a companion diagnostic is. Not only that, as a new drug is developed for Parkinson's disease, simultaneously with it, a diagnostic assay is designed to predict which patients would have a beneficial response. So let's take a look at some examples. Now, this is an example of going backwards using a diagnostic test to predict the response or lack of response of a therapeutic agent. In colon cancers, there are several genes that are classified as mismatch repair genes, and they express a protein. The expression of that protein can be measured using IHC, or whether or not that protein is expressed can also be done by PCR or sequencing. If a patient has colon cancer and does not express those mismatch repair proteins, that is, the genes aren't active, those patients don't respond to chemotherapy, which means that you don't want to give those patients chemotherapy. It's giving chemotherapy unnecessarily. Now, this is an example of a companion diagnostic that predicts that a drug doesn't work for a drug that was produced a long time ago. And now let's move into the 21st century. This is a slide that Andrew showed earlier, and I want to just use a couple of examples. In the middle of the slide, at the bottom, is identified a drug named Xalkori, or the generic name is crizotinib. Xalkori is a drug which works in about 5% of patients with lung cancer. But it works very well in those 5%. So patients with a certain kind of lung cancer can have a diagnostic assay looking for rearrangement of the ALK gene using an IHC, immunohistochemistry. And for those patients who have it, it's only 5%, but they have an excellent response to this drug. That is a companion diagnostic. The IHC assay specifies Xalkori in the diagnostic assay in the IVD, and Xalkori specifies the assay in the package insert. Another example that all of you may be more familiar with are the diagnostic tests for overexpression of the HER2 new gene in breast cancer. About 15% of patients with breast cancer, men and women, will have overexpression of the HER2 new gene. And this can be diagnosed either by IHC or by FISH. And if there is overexpression of that gene, then those patients respond to Herceptin or trastuzumab. And again, in the trastuzumab FDA package insert, it specifies that one of these assays should be used to detect overexpression and vice versa. And they are launched, if not on the same day, within months of each other. So this is where physicians are looking for help. So when I'm asked, will physicians be receptive to this concept, and do physicians like the concept of companion diagnostics, the answer is overwhelming. And it's emphasized on this slide. No patient wants to receive ineffective therapy. I can tell you that from the patients I see in my office, and I can give you my perspective that no doctor wants to prescribe it. And what we can say that is coming in the future is a better solution that is companion diagnostics. Thank you. I'm going to turn it back over to Andrew.
Okay, thank you very much, Dr. Joseph. We're now going to switch gears, and we're going to pass the baton over to Dr. Frank, who, as I mentioned before, is our Chief Medical Officer in Siemens Healthcare. And Dr. Frank is going to talk about the U.S. healthcare environment, the challenges and opportunities for companion diagnostics. Dr. Frank.
Thanks, Andrew. I'm grateful for this opportunity to share with you some of our thinking about the changes in the delivery of healthcare in the United States and the opportunity that that represents for companion diagnostics. The providers of healthcare in the United States are facing a number of pressures, or what is described on this slide as macro trends, and they're reacting to those trends in a number of ways. My following few slides will go into some more granularity on each one of these, but I'll just summarize now by saying there are demographic changes in the United States. There are obviously changes in expenditures for healthcare. Consumers, that is the patients, are taking on increased liability, and by that I don't mean legal liability, I mean liability for their own healthcare costs. And finally, there are a number of government mandates which bring more pressure to bear on the providers, and their responses are manifold. There's consolidation, that would be mergers and acquisition activity among hospitals and other care providers. They're economizing both in capital expenditures and in operating expenditures. They're embarking on new investments, not just M&A, but other investments as well to prepare for the future. And finally, they're preparing primarily for a transition from fee-for-service to fee-for-value, and ultimately perhaps something like capitation. Now on this slide there's a lot more granularity. I won't talk you through each one of these, but on the left we see a more detailed version of those macro trends, and on the right a more detailed version of the provider reactions. And the main point of this slide, which will be available to you on the website later for more detailed review, the main point of this slide is among these macro trends there are a couple, such as the demographics and the Affordable Care Act, which will tend to have a favorable impact on the demand for health care. And yet you see that these are yellow rather than green because they're not unmitigated favorable impacts. And all the rest of the trends, such as the trend in national health care expenditure, are actually downward and represent pressures on the providers, which is leading to the reactions that you see listed on the right, such as consolidation among hospital delivery networks, the economizing to which I referred earlier, but also innovation in the delivery of health care, which likely will have a beneficial effect, such as reaching out into the community for things like obesity and smoking and so on. So as we consider more granularity in what these trends represent, you see on the left-hand side here the population or demographic trend. And what you see is actually three components here. One of them is the overall growth in the population, so there's an upward trend in the total size of the population. But in particular, you see that top bar is the people in the older, the 65 and over age group. Not only are the baby boomers now coming into the 65 and older age group, so there are more and more people in that category, but also the people, once they achieve the age of 65, are living longer. And therefore, there are these three trends: the overall growth in the population, the growth in people achieving the age of 65, and their longevity from the age of 65 are leading to increasing demand because the older population have a greater utilization of healthcare resources, in particular procedures, including diagnostics. On the right-hand side, you see this boiled down into the impact on procedure volume, which includes all diagnostics, in particular in vitro diagnostics, and including companion diagnostics. And you see our estimate by 2020 is at the low end a 10% increase in demand, and at the high end a 20% increase, and that's across all procedures. For in vitro diagnostics, particularly relevant to you, we're estimating something approximately in the middle of that range, so about 15% growth in demand for the services that you provide. Now, on this slide, we see another one of the macro trends, which is the national health expenditure. In the chart on the left, the blue line, the one at toward the upper end of the graph, represents the expenditures for health care. And you can see that the 4.2% figure, which is the current spend, has been considered quite a victory as a significant reduction from 7% in recent years. But there are two key points there. One of them is it's unlikely to remain as low as 4%. It probably will grow again to 6% or so per annum in the not too distant future. But the other, even more important point is that even at 4%, the growth in national health expenditure is greater than the growth in the gross domestic product. And therefore, our spend on health care has been outstripping the growth of wealth in the country. And therefore, there are responses to this and sort of back pressure on the national health expenditure. The graph on the right is intended to translate that 4 or 6% per annum growth in healthcare expenditure into a compound annual growth rate. So lest you think that 4 or 6% isn't really very much, in fact, as a CAGR, the compound annual growth rate, you can see that this leads from $2 plus trillion today to over $4 trillion by 2020. And therefore, this is really a much bigger number than one might have guessed. And this is driving behavior not only on the part of public payers like Medicare, but also private insurers. Now, in this slide is portrayed another important shift. You remember I mentioned liability on the part of the consumers, or you and me. Employers in particular are shifting the cost burden to employees in a couple ways. One of them by offering high deductible plans, and so in an effort to control their own personal costs under high deductible circumstances, the individual patients may choose to access health care less than they had in the past, certainly be more judicious in that process. And in the central box you see on this slide, you see that employers are also adopting what's called defined contribution plans, which means rather than providing the health care as part of the compensation package, they provide a certain dollar amount for the employee then to use in buying health care on their own. And so in the right-hand column you see a summary of these trends, and the net effect here is for the employers to be pushing on to their employees responsibility for their own care, which will affect the decision-making by individual patients. Now, this slide refers to the thinking of the providers. Remember, we talked about macro trends and how the providers are reacting to those macro trends. These are two surveys of the C-suites in hospital networks where they're making decisions about investments. And in the left hand, the bar chart, you can see from left to right the predictions for investments into the future. And on the left-hand side, you see only 2% believe that they will increase their investment by 25% or more. And in the right-hand half of the graph, you see that more than 65% believe that they will either not increase or will decrease by as much as 25% their investment. And in the right-hand box on this slide, you can see part of the reason for that. When they're asked in a forced ranking survey to say what are the most important things driving their behavior in investment, you can see financial challenges at the top of the list. Now, we're happy to see second on the list is the patient safety and quality, and this is an important driver for the incorporation of diagnostics to ensure patients remain to receive good quality health care despite the financial challenges. You'll also see kind of sneaking onto this list population health management, and this is something to which I alluded earlier. As providers take on more and more risk in providing health care, it's becoming clearer to them that helping their covered lives, shall we say, the people in their network to reduce their weight, to stop smoking, to manage other risk factors, now is actually in the interest not only of the individual patient, but also in the interest of the provider in order to reduce the demand for health care. Now, this slide is intended to portray the shift from fee-for-service, as healthcare has been in the United States these many years, to fee-for-value, as we anticipate, well, in fact, is already happening. And it remains an open question how rapidly there will be this transition, and we continue to monitor that. But the fact is that transition is occurring, and it amounts to a shift from primarily where under fee-for-service that the volume of services is incented because the people are paid for each service that's provided. And under these circumstances, diagnostics such as imaging and other testing, including companion diagnostics, represent profit centers. And under these circumstances, IT is a sort of a nice to have. In the future, under the fee-for-value circumstances, then volume is actually disincented. Imaging and other diagnostic tests become cost centers, and IT is a key enabler for this in order to ensure optimal use of healthcare resources for good outcomes. And so under these circumstances of shifting from fee-for-service to fee-for-value, the potential, the temptation will be simply to limit access, to reduce the number of procedures being offered to the patient in order to manage the provider's cost base. But we're quite confident that the deliverers of healthcare will continue to see that the appropriate use of diagnostics is actually an efficiency in order to make the best choice of therapy, not only for the best outcome for the patient, but also for the most efficient use of hospital resources. For example, getting people out of the hospital sooner, back to work sooner, which is in the interest of their employers, and also reducing the rate of rehospitalizations. So we're quite confident that even under the fee-for-value circumstance, that certainly in the medium and long term, there will be seen value in optimum use of diagnostics. Now, in this slide, there is a very important concept of driving the behavior of providers, and that is the risk that they're taking in the payments that they receive from, for example, Medicare on the left. The bar charts on the left indicate the combined effect of a number of incentive programs that Medicare have established. One, the value-based payment, others having to do with rehospitalization and hospital-acquired infections. Now, the amount of reimbursement from Medicare, which is at risk for these quality measures, is, shall we say, only 6%. And yet, how important is this to the hospital? The importance of this to the hospital becomes clear when you understand that fully 1/3 of a hospital's revenue is derived from Medicare patients on average. And if 6% of that is at risk, that's fully 2% of the hospital's revenue. Hospitals make about 6% profit on average, and so you can easily see that 2% is a third of 6%, and therefore fully 1/3 of a hospital's profit is at risk as a result of these incentive programs from CMS. And therefore they're very much driven to deliver quality and are changing the way they deliver health care in order to ensure that they get those payments. In the right-hand chart, you see the additional effect by which CMS is catalyzing a broader payment reform, the shift from fee-for-service to fee-for-value, by way of the accountable care organizations represented by the gray bars on the left, and also bundled payments, which you see in that the blue bar just second from the right. A bundling of payments means that things that commonly are offered together in the hospital, whether it's a procedure, a service, or a therapeutic intervention, those things can be paid in a bundle, and therefore the hospital is incented to be efficient in choosing perhaps the lower cost item among those, or even leaving some of those procedures out. And so it is a very important way for CMS, by bundling, to shift the risk to the providers, and it's up to the providers to ensure that they continue to deliver quality of care, not simply restrict access in order to save money. Now, this slide captures some of the demographic changes, but from the perspective of insurance. We all hear in the news quite frequently now about the impact of the Affordable Care Act, and there are two components to that that suggest in the long run there'll be an increase in the number of insured patients by about 25 million, which is the top line on this chart on the left. That comprises two components. One of them is expansion of patients eligible for Medicaid, which is a decision on a state-by-state basis, and the other is the people who are buying insurance on the health exchanges, and I'll address each of those separately. Patient eligibility for Medicaid is defined by the states and historically has been 2 times the federal poverty limit. What the Affordable Care Act proposed was that states should change that definition to 4 times the federal poverty level, and some states have chosen to do that, other states have chosen not to, and some states are still deciding. So whereas the total impact might have been 12 million, it probably will be, well, it certainly will be something less than that, because some of the states have decided not to expand Medicare in their states, and yet there still will be many millions of additional insured Medicaid patients. Addressing the exchanges, we've heard these numbers quite a bit in the news lately, and I think the numbers probably are a little smaller than what we hear for a couple of reasons. One is not everyone who signs up actually pays their, makes their payment, and therefore do not effectively get coverage. And also some of the people were covered before, so they don't actually represent newly insured patients. Even with those caveats, once again, there'll be millions more patients who are covered, and this represents an increase in revenue opportunities for the hospitals. What you see in the right-hand column here is the anticipated impact of that increased insured population on procedure volume, and it will grow over the next few years as more and more people come under Medicaid or gain insurance through the exchanges. But we think an equilibrium will be achieved in the next few years, and that will be somewhere between an increase of 5 and 10% in demand for procedure volume. So in addition to the demographic trend we saw earlier, there is this additional impact of increased insurance. Right. Now, we think that as regards the specifics of diagnostics, that it's important to understand the benefit of early and accurate diagnosis for the overall impact on the better outcomes for patients, but also efficient use of hospital resources. And so we define early as early relative to the rate of progression of the disease, or early relative to the intensity of the therapy involved. And in general, a disease which is identified earlier can be treated more effectively at lower cost, at lower intensity of intervention, and at sooner resolution. And so the value of that early detection is seen not only by the patient but also by the hospital delivery system. By accuracy, we mean that the caregiver has confidence in the etiology and therefore the patient management decisions that they would make based on that etiology. And by diagnosis, of course, we mean the label for the pathophysiology which informs that choice of therapy and ultimately downstream coordination of care. And an important component of this is staging, which is helping to characterize the particular progression of that pathophysiology in order to inform the best choice of therapy, and cancer is the most obvious one. The decision about which chemotherapy to apply depends in part on the presence or absence of metastases. So we use staging most commonly in that regard, but really in many diseases in order to make the best choice of therapy. Using diagnostics in order to not only identify that the patient has the disease, but to characterize it for the state of the pathophysiology is crucial to making the best choice of treatment. Now, Dr. Joseph earlier referred to the parallel development of an experimental therapeutic and the companion diagnostic. And this chart is from a publication of mine which first appeared in Nature Reviews in Drug Development in 2003 and was updated in 2011. You see the bibliographic reference at the bottom of the slide. And as it cascades from the upper left to the lower right, this chart represents phase 1, 2, and 3 development of an experimental therapeutic. And at those stages, what will become a diagnostic is considered a biomarker. It's used to stratify the population and perhaps also to measure the response to the experimental therapeutic. And then once this clinical evidence is gathered during this research and development phase and is presented to the FDA, the evidence can support not only the approval of the therapeutic for its response in a well-characterized population, but the same clinical evidence supporting the role for the diagnostic, for the biomarker come diagnostic, so that there is this sort of coordinated labeling to provide instructions to physicians about how best to prescribe the drug based in part on the results from the use of that companion diagnostic. So there are a number of implications for this new way of developing drugs, and the Food and Drug Administration have recognized that. The definitions you see on this slide derive from the FDA, and you can see the link there in the bottom of the slide. The main point here is that the FDA recognized that this is the wave of the future, and they're preparing the regulatory infrastructure and pathways necessary to do a good job of ensuring safety and efficacy, not only to protect the American public, but also to foster better medicine. In a little more granularity, the FDA policy has been stated that it is essential for the safe and effective use of a corresponding therapeutic product, and they have issued a guidance in draft form, which we would advocate being issued in final form, with a number of things being addressed in order to optimize this regulatory pathway to ensure not only safety and efficacy, but also minimize the risk of such a burdensome regulatory process that it would effectively block new products from coming into the market in the United States. And I should add that because of the good coordination with regulatory agencies worldwide, we fully expect that progress in the United States would soon be followed in Europe as well. So we see this as not only a regulatory opportunity to optimize bringing new products into the marketplace, but also an opportunity to get coverage and payment, jointly known as reimbursement, to get that optimized as well, because it's important for private insurers and for CMS or Medicare and Medicaid to cover these appropriately. And so as they bundle, or another word is packaging, so that they're making one payment for a bundle of procedures and treatments and so on, these should not inadvertently disincentivize investment in novel diagnostics by the payments being too low, but instead there should be rewards for innovation in the development of companion diagnostics because of the prospect for improved outcomes and overall efficiency in the delivery of health care. Another recent factor is the clinical laboratory fee schedule reform. It's uncertain what the impact of this will be, but it's clear that CMS intend to pay a weighted average of private sector prices beginning in 2017. And so there will need to be some rulemaking for the fuller implementation of this new law, and we look forward to having a favorable impact on that so that it's realistic both in its implementation and in its evaluation. We think that coverage for companion diagnostics should be with immediate effect from FDA approval, because the FDA's review of safety and efficacy should be adequate for the purpose of determining that this is reasonable and necessary, and specifically the cross-labeling of the diagnostic with the therapeutic should make it clear that the use of that diagnostic is not only reasonable, but is necessary for the appropriate use of that therapeutic. And then finally, appropriate use criteria you've probably heard a lot about recently, because this is the manifestation of evidence-based medicine. It's good medicine, and if derived from the clinical evidence that was generated by the development of the experimental therapeutic, clearly showing the role for what had been a biomarker doing R&D and now as a diagnostic, as a companion to the therapeutic, it's quite clear that this would be an appropriate use for that. And so with that, I'll just summarize by saying that companion diagnostics offer the prospect for better outcomes for the patient, which can be achieved with greater efficiency for the healthcare system, and we're quite confident that this is the wave of the future. Thank you.
Okay, Dr. Frank, thank you very much for that insight into the healthcare world here in the United States. We're now going to move into a panel discussion, a Q&A, in which people can present their questions for Dr. Franks and Dr. Joseph. I think on your screens on the left-hand side you should see a little button called Q&A. If you have any questions, please put your questions into the Q&A text box, and we will receive them over here, and we'll be in a position to pose those questions to our experts. And we've got a few minutes left before we get to the hour, so please start to submit your questions as soon as you can. So what I'd like to do is, we've got one or two questions here already that perhaps you'd like to comment on. One is, you know, in the audience there's going to be, obviously, it's majority of the folks here are the lab testing community. We've got lab directors there, and I'm sure they must be asking themselves these kinds of questions about, well, you know, there are a number of companion diagnostic tests out there today. There'll be many more on the horizon through, obviously, the work that's going on right now with the alignment of the test development programs and the therapy development programs. You know, how are they going to deal with situations where potentially the therapy is available, the test is actually available, and yet it may be inadequately reimbursed? So do you have any thoughts on that, perhaps, Dr. Franks?
Yes, I alluded to this somewhat in my formal remarks. The concern is that as hospitals face the financial reality of trying to sustain what amounts to a business, in the face of so many financial pressures, the temptation will be simply to take cost out by providing fewer services and using diagnostics less. We're quite confident that in the long run they will see that the use of companion diagnostics is not only good for the patient but also good for the efficient use of healthcare resources in their hospitals. And yet in the short run there may be this risk of limited access, and I think for the individual caregiver who is here not so much operating a business but is here to provide medical care, they will continue to take a patient-centered approach to this. They know what's best for the patient. They are effectively advocates for the patient. And it's incumbent upon each of us to advocate for that patient by choosing the right diagnostic tests in order to make the best therapeutic decision for them. And if that results in some cost pressures on the hospital network because the payments are inadequate for that, they should not be bashful in raising that issue with the payers, whether private or public. So I think this tension is very likely in the coming years. I think the patient-centered approach makes it incumbent upon us to continue to provide the services and the treatments that the patients need, but that we can't be bashful about flagging up to those who are making the payment decisions of the essential nature of these services and the inadequacy of the payments, and effectively fight that corner, not only on behalf of the sustainability of the business of delivering health care, but ultimately on behalf of the patients as well.
Okay.
And Richard, let me ask you, from our previous discussions and when you've talked about this in your experience, some of these companion diagnostics may be very, very expensive. And I don't mean the charge, I mean the cost of doing the test can be very expensive. And of course, the concern is that the reimbursement will be less than the cost. But if this test is run, and let's assume that we're dealing with a Medicaid beneficiary, if this test is run on all patients with a given disease, can't that be presented to the FDA in a way that this really is driving value, meaning we're determining which patients to treat and, more importantly, which patients not to treat with expensive drugs? And in your experience, is that a legitimate argument for getting better reimbursement?
Well, certainly, yes. The short answer is yes. The longer answer is that the clinical evidence to support that argument comes from the parallel development of the therapeutic and the diagnostic and the R&D for the experimental agent. And so as FDA have approved that, the safety and efficacy of that, the essential nature of the diagnostic as a companion to the therapeutic is clear. Part of what FDA will have done is reviewed the response rate and for those who have a positive result on the test as compared to the response rate on the negative, people who have negative results on the test, and that's the basis for approval. So the value of the test is, as you've alluded, identifying patients who are likely to respond, and therefore the value of that therapeutic to them is greater. And you've also avoided then the unnecessary expense of treating patients who won't benefit from it. And beyond that, it's not just a matter of expense. Most drugs have some adverse effects, and patients have varying susceptibility to that. But even the small susceptibility, even the relatively minor adverse effect, is something that a patient shouldn't suffer if they have no likelihood of response to the treatment. So it's not only a matter of saving money by not treating patients who won't benefit from the drug, it's also a matter of saving them exposure to the risk of the adverse effect. So there's value not only for the patients who have a positive result to the test and therefore we know are more likely to respond, but there's also value to the patients who might be put at unnecessary risk of adverse effects.
Thank you.
Okay, thank you very much for that response. We're getting a number of good questions coming in here. So I do apologize to those folks who are submitting the questions, because I'm going to somewhat paraphrase them in the interest of time. I've got a question here. It's actually talking about complementary diagnostics. Now, we talk about companion diagnostics, but are they really? You know, this maybe goes to the overall definition of what a companion diagnostic test is all about. Are they really diagnostic?
Well, I'll deal with that.
Dr. Joseph, you can answer that one.
The term diagnostic has many definitions. And those of us who also work in the laboratory have a tendency to use the term diagnostics as any test we run or any analyte. And really it is a diagnostic assay, but it's not diagnosing a disease. It's defining a patient's result. So a diagnostic may be an electrolyte panel, but that's not necessarily diagnosing a disease. As was pointed out so well earlier by Richard, a companion diagnostic has a very specific definition from the Food and Drug Administration, and that is, it is a test that is essential for the safe and effective use of a drug.
And if I could expand on that a little bit, I think what Patrick says is perfectly right. In many cases, what we call a diagnostic test, such as for an electrolyte or glucose or something, is not actually making a diagnosis. It's detecting something which becomes a component of a diagnosis. Yeah? And so I often use the word detection rather than diagnosis to describe what we're doing. At the other end, the use of a companion diagnostic is actually higher value even than the diagnostic, I would use the word prognostic, because it's telling us what is the likelihood of response to a particular treatment. And if we know that it's more likely that this patient will respond to this treatment, that gives it greater value. And that's actually making a prognosis for what the course of disease is likely to be in this patient, in particular, as treated with that particular drug. So at the front end, you have what we call diagnostic tests, which are really just detecting something, and they need to be taken in a much broader context of all the other components that lead to a diagnostic. At the other end, you have a very high-value companion diagnostic, which is really leading directly to the choice of a therapy that's very likely, more likely to be beneficial for that patient.
Okay, thank you. Okay, we've got a question here, which is quite operational in terms of how it's pitched, but it's about when you introduce these companion diagnostic tests are often new to the testing community. So the question is, first question is, who provides the test? But I think perhaps more importantly is, what's the view in terms of the quality assurance, the proficiency testing of these kinds of new to market or new to the testing community type tests? That's kind of, maybe Dr. Joseph, you may have some views on proficiency testing for these kinds of new tests.
Well, we should go through the sequence, considering the audience for this webinar. The sequence that is typical as a drug is being developed, if a biomarker is thought to be predictive for the successful use of a new drug, then typically a laboratory-developed test is the companion diagnostic to it. And so that has to be developed in a laboratory that has the ability to generate an LDT. And when the first thing that happens, of course, that most people know, is that we do analytical validation. We have to determine the accuracy and the precision, and in order to do that, perhaps make internal proficiency testing controls.
Right.
That's the first step. So we've got a test that's reproducible, that's relatively accurate, that's got proficiency testing. Then as one moves forward with usually the pharmaceutical company developing the drug, then there is clinical validation. So we start off with analytical validation, then clinical validation on clinical trials, and if those are successful, then the next steps that we have seen in the past are to commercialize that assay and turn it hopefully into an FDA-approved kit that can be disseminated to laboratories around the world.
Okay, thank you. We've got another couple of questions popping up here. Now, I know that we've focused on obviously the US perspective on companion diagnostics, certainly the regulatory side of it. I think, Dr. Frank, you mentioned that. What do we know about what's happening, in other parts of the world for companion diagnostics?
Mm-hmm. Well, in the United States, there's been a draft guidance which we would advocate being finalized with the additional points, as you saw in my slide. We think that the Europeans are prepared also to modernize their regulations around this, to tidy up and prepare for this future in which there are more and more of these tests with the sort of sophistication and validation and so on to which Dr. Joseph just referred. And so we anticipate in the next couple of years that just as in the United States, so also in Europe, will there be an enhanced sophistication in the regulatory pathway, which on the one hand will enhance the likelihood of quality and safety and efficacy, and on the other hand, not create such a burdensome pathway that these products can't become available to patients.
Okay, thank you. Well, unfortunately, we've got a couple more questions here, but I don't believe we've got sufficient time to complete them because we're about 1 minute from the end of the hour. So I think it's probably, for those folks who've actually submitted additional questions, we will try and respond to those offline through our experts. But given we're so close to the hour, what I'd like to do is draw this webinar to a close. So on behalf of Siemens Healthcare Diagnostics, I'd like to thank our speakers very much for participating in this event and for their contributions. But I should also like to reach out to the online audience also for setting aside their valuable time to listen to this webinar today. thank you very much for your attendance, and if you wish to follow up with more information on what we do, Siemens Healthcare Diagnostics, in the companion diagnostics space, you'll see on this final slide a URL that you can go to, and it gives some details around our interests in this space. So thank you very much to everybody for participation, for listening to us. We wish everybody a great day, and we will say goodbye. Thank you.
Thank you.